It gives me great pleasure to introduce you to Joe today. But just before I do, I just really want to quickly go through NTT and why we're doing today. And NTT annually spends about $3.6 billion on research and development. And that's about 5.2 billion Australian. And a lot of that is spent on the concept of achieving society 5.0. And if I can try and explain 5.0 to you the easiest way, it's about the betterment of society through technology. And an example is in society before, we all use GPS systems. That's where we are today. We push it. But society 5.0 is about self-autonomous cars and about their ability to drive you and reduce the number of accidents and reduce the number of deaths and thereby improving society. And so NTT invests extensively in the achievement of 5.0 through our NTT research, which I explained to you. Secondly, that we spend about 3% of our revenues in that area. It gives me a lot of pride to work at NTT, to know that we do that. And part of the area we do it is in three particular areas. One is our PHI labs, which is all about investing in next generation quantum computing. The second area is in our CIS labs, which is about if you've got that computer, how do you secure it? And we know that cybersecurity is a critical area, so there's a huge investment in that area. And the last one, and the reason we're here today, is our MEI labs, which is about a vision for the future for, in particular, healthcare. And with that, it gives me the greatest of pleasure to introduce Joe Alexander here today. So, Dr. Joe Alexander's background is in engineering and medicine. After he graduated with a degree in chemical engineering at Auburn University, he studied medicine as a fellow at the Medical Science Training Program at Johns Hopkins Medical School, where he received his MD and his PhD degree. His PhD degree is in biomedical engineering, where he's a specialist in cardiovascular dynamics. He completed a fellowship in research cardiology at Albert Einstein College of Medicine, where he went to train on astronauts and people such as Dr. McKay for the Neural Labs space science mission. Following academia, he entered pharma, first at Merck and advisor, but importantly, Dr. Alexander is also the Director of Medicine and Health in NTT's Informatics Laboratory. And with that, you're all here to listen to Dr. Joe Alexander, not myself, so I'll hand over to Dr. Alexander.
Thank you very much, Mark. It gives me great pleasure and enthusiasm to be before such a remarkable crowd. And I'm very humbled very much by the fact that we have two greats of cardiovascular medicine in the room, Professor Andrew Coates and also Dr. Kenji Sunagawa. About 3.5 years ago, Gomi-san, my CEO, said he wanted me to work on development of a biodigital twin. He asked what we needed in order to be able to be successful. I said, first, we need to work on the cardiovascular biodigital twin, number one. Number two, we need Kenji Sunagawa. Many of the concepts that we're using in cardiovascular dynamics were generated or greatly refined by Kenji. And Kenji and I go back 43 years. I trained with Kenji, so did Dan Berkoff in Kenji Sunagawa's lab. And just to say, my first son's name is Kenji. Our approach for thinking about the biodigital twin comes from the aviation industry, in effect, where each engine is modeled or completely simulated, and data is streamed from each engine. Various types of data is being collected when the plane is in flight, and all that information for each engine is streamed to the ground or is downloaded once it's on the ground, and then the model for that engine is updated and so forth. It's possible to collect data from multiple engines, from multiple aircraft, and generate more deep insights into the behavior of the particular engine. And so we think that there's a pretty good analogy with healthcare in terms of real-time support for decision-making. In each case, you have a virtual representation of some real object, It can be used as a design tool for doing what-if scenario testing. And the basic idea is that, for example, for the aviation industry, those engines, you don't have to maintain the engine on a regular schedule. You can do predictive maintenance to know when you need to maintain the engine. And we have the notion that you can have predictive health maintenance as well, so that based on various types of data, to predict when you need to go into the hospital, to take care of some, or to kind of anticipate acute exacerbations before they actually happen. And then because of the continuous monitoring of data, you have a possibility for continuous optimization. So this is the kind of notion from the aviation industry to healthcare, and in particular, we're focused on the cardiovascular system. That's how we think about the biodigital twin currently. The two main areas of research interest and focus for the May Lab are this kind of overall cardiovascular biodigital twin, which is based a lot on population-based data where we generate biodigital twin populations, and then we try to figure out what patients within that biodigital twin population is closest to an individual patient and go from there. Whereas the other interest of ours is kind of hard-on-the-chip technology, which is very patient-specific, where actually in our incarnation of hard-on-the-chip, we're collaborating with Technical University of Munich that develops nano devices and various types of sensors for measurements of various types of mechanical and sensory characteristics. And we're collaborating with Harvard University, a professor named Kit Parker, who turns out to have been a graduate student of mine when I was at Vanderbilt. But now he's renowned for being able to spin and create a left ventricle or a ventricular shape based on a patient's own iPS-derived stem cells. So you can't get more patient-specific than that. So on the one hand, we're using a lot of population-based data to try to figure out where our patient fits within that data. And on the other hand, we're getting a patient-specific information and combining that through what we like to call precision cardiology. Well, not just us, others that recognize it as well, as in this publication, where you can combine population-based data, patient-specific data, and perhaps get a better idea of or a better handle on how to treat a particular patient. So it's an effort toward personalized medicine. Now, the reason we chose the cardiovascular biodigital twin as the first incarnation of moving toward the biodigital twin as a whole is because, first of all, the blood runs through every organ of the body. And perhaps most importantly is that most of death across the world is due to cardiovascular disease. And so we thought that we could have a big impact by going after the cardiovascular system as first effort. I mentioned already, but I'll say a little bit more. We have joint research agreements with the National Cardiovascular Center in Osaka. And actually, Kenji used to be chairman of the Biomedical Engineering Group there, and he actually helped us set up this joint research arrangement. Kenji is working as a consultant with NTT Research. And Harvard University, I mentioned earlier, working on creating a kind of in vitro biodigital twin or the hard-on-the-chip technology. And then Technical University of Munich that's focused on microscale sensor capabilities. We are working with Embody Bio, which has a causal inference platform that will help us ultimately make the translation from animal data to human data. We're doing animal experiments because we can get highly invasive measurements of hemodynamics, and we need to translate that through various processes, including allometric scaling, to be able to get to human data, where we can't actually make such invasive measurements. I should say at the outset that we are focused on acute conditions because we think we can have more invasive data, and we need to validate our models on the basis of hemodynamic data. We're offering NTT fellowships from the May Lab And so far, we've handed out 3 fellowships, one at Johns Hopkins Department of Biomedical Engineering. You can see the bias in biomedical engineering here. Vanderbilt University, Biomedical Engineering, and Georgia Tech. In the beginning, when I thought to model the cardiovascular system, I was thinking computational fluid dynamics. And Kenji said it was far too complicated for all of the systems that we need to bring to bear for the management of acute heart failure and acute myocardial infarction. We need a simpler approach because we need to do more than just represent fluid dynamics. We need to add additional systems such as renal system, humoral control mechanisms, pulmonary mechanics, and so forth. And so we need to start with a very simple model. And we have a lot of history with electrical analog models from the group that I come from, where the voltage is analogous to pressure, charge is analogous to volume, flow of ions is analogous to blood flow. So we can create a log representation of cardiovascular hemodynamics in that way. And what you see shown here is a basic model of hemodynamics based on the electrical analog business. Where you see diodes, those represent valves or one directional flow, but we can set up circuits where there could be regurgitation and so forth as well. On top of that basic model, we're adding a cardiac conduction model, cardiac energetics model, which is going to be critically important for some of the work we want to do, a lung and oxygenation model, a renal model, and humoral control model. One of our aims, and this is something that Kenji Sensei has been working on for a very long time, and that is around autonomous closed-loop therapeutics, which is where basically like a self-driving car, where you give a command to some system of syringes that have various types of drugs from different classes, catecholamines, nitrates, diuretics, and you dial those and send them to the patient and watch the patient's response. And depending on that response, that error signal between the command and the response will drive toward a correction, kind of like a self-driving car. I'm sorry, for that, we need to do various things, create a feedback control system for sure, but because we want to know the impact of these various drugs or devices on the parameters in our model, the resistors, the capacitors, and so forth, the system characteristics, then we need to figure out what those relationships are. Current pharmacology is not designed around understanding the impact of a drug on a resistance or on a capacitance. So we have to create a device library, a drug library, in order to know how much of an effect a change in a drug might have on the particular parameters in our model, so the actual system characteristics. So with that simple kind of basic model, electrical analog model, we get results that look, at least in quality, similar to what we see in terms of left ventricular pressure, aortic pressure, the various left atrial pressures, mitral flow, aortic flow, and pressure volume relationships, which are standard important hemodynamic system characteristics to look at when understanding a patient's cardiovascular dynamics. Sorry. Right now, we've completed the basic model. We're working on the enhancements, which include these various subsystems that I mentioned earlier. Right now, we have this gap to be able to get to the point of representing a patient with disease and providing autonomous closed-loop therapeutics. Actually, although this looks like a kind of linear progression or exponential progression, we're getting close to patient-specific therapeutics already, in the sense that we can foresee that happening in animal preparations in the near term. Now, probably tomorrow we could make this work just in terms of autonomous closed-loop therapeutics. But what we're aiming for, and this is the challenge, is to have myocardial oxygen consumption or metabolic optimization be the thing that drives the autonomous closed-loop therapeutics. Because if you had an acute myocardial infarction, acute heart failure, then you want to have the heart rest and recover and do the minimum amount of work and get the necessary amount of oxygen to optimize the heart's ability to recover. And so this metabolic optimization is what we're striving for in this autonomous closed-loop therapeutic notion. Various things are involved in moving and progressing along this trajectory. This is a representation of the overall system once it's complete. So far, as I mentioned, Kenji helped us negotiate the relationship with the National Cardiovascular Center. And that center is very special because of the history of cardiologists and physiologists who were doing many animal experiments, who were also engineers, and who understand hemodynamics very well, mostly because of the legacy from Dr. Sunugawa and his time at the National Cardiovascular Center. The person who's the acting director right now for that biomedical engineering group actually recently trained also under Kenji at Kyushu University at Saku. So we've had several years of working with our National Cardiovascular Center doing animal experimentation to validate some of our choices for the basic model and the enhanced model. But this year we signed an agreement with a little more of an investment that aims to help us move from not just animal experimentation, but to work also with the hospital. So for the first time at the National Cardiovascular Center, we have created a biodigital twin center that's focused on being able to make that progression from animals to humans. It involves anesthesiologists and cardiologists and physiologists, and it will provide access to patient invasive clinical data. And because the National Cardiovascular Center is a national center, then they get patients referred from all over Japan. And so it will be a nice access, data access for us to help us make the translation from animals to humans. So that translation from animals to humans is a big job. And it will require some level of causal inference, and as I mentioned, we're working with Embodied Bio on their platform. We need to do allometric scaling. Not all of the measurements we can do in animals can be done in humans, and so we need to find out how to do that kind of scaling up to humans. The wonderful thing about the National Cardiovascular Center is that they do multiple sized animals. So from rats to dogs, to pigs, to goats, to cows. And so that helps in this kind of study of how to allometrically scale from the size of a dog, which is where we do most of our experiments, to the size of a human. We're modeling the renal vascular system, looking at pressure diuresis. I mentioned earlier, we're looking at the drug library, but also eventually we'll be developing a device library. This is the notion for autonomous closed-loop therapeutics, and I've shown just 3 syringes to represent several classes of drugs, perhaps catecholamines, nitrates, and diuretics. But there could be a whole library of drugs, and the same system, the same control system for drug delivery could involve device delivery and so forth. That slide was just to indicate that we're in the process of making a movie to try to explain what autonomous closed-loop therapeutics is. And actually, in the beginning, we were very interested in doing it ourselves, but now we're just interested in publications and IP. and just hope somebody does this. And so we're trying to help people realize and dream to be able to achieve this because it's important. Kenji, I forgot to take out this part about thrombolytics, which no longer indicated in the slide. But I was writing a script of my imagination, and we have some people who are working on developing that movie, which will be available probably by the time of our NTT R&D forum in November. And there'll be some actors involved and so forth. One thing about the cardiovascular system that every cardiologist knows is that there's a certain amount of compensation that happens always throughout the body under disease circumstances, where the body has a number of autoregulatory systems, that try to keep things normal, even when things tend to want to fall apart. And that's so-called a compensated system. But there comes a time, or perhaps, where the last final insult will cause the whole system of cards to fall, and that's called decompensation. Usually that's something that would surprise a physician because everything looked fine and then suddenly it's not. We think that through this type of biodigital twin, cardiovascular biodigital twin, we can explore a kind of boundary surface, if you will, where we can stay away from places that might likely lead to decompensation. So we can map out that space is one expectation, and try to avoid so-called autoregulatory exhaustion where the system just crumbles. So we have certain design objectives for this autonomous closed-loop therapeutic system, and we're focused again on acute myocardial infarction and acute heart failure. So we want to facilitate management of acute exacerbations in chronic heart failure patients who are hospitalized or re-hospitalized. This kind of system, if we understand our device and drug libraries, is such that we wouldn't give one drug, wait, see the effect, give another drug, wait, see the effect, and so forth. We could give all the drugs at once if we fully understand the system. And we've worked out and understood the impact of combinations of drugs or devices on those characteristics of the system. We can predict situations where, and we have, at this conference, we have, or at the past IEEE conference, we had some results that we showed. We can predict situations where no combination of drugs will ever work. And so it helps support the decision to move to device therapies is one impact. I mentioned autoregulatory exhaustion. We can optimize drug-device combinations. There's certain combinations of devices where, for example, if you have an Impella and you add ECMO, certain settings are more or less arbitrary or recommended based on something arbitrary, but we can find the optimal combinations of devices combined also with drugs. It's what we are aiming to do in these design objectives. I mentioned optimizing myocardial oxygen consumption for the weakened or damaged heart so that it can optimally recover. Such a system would help with health equity issues for countries that may not have significant resources. They can still get high quality care using less specialized staff to monitor autonomous closed-loop therapeutic system. And then there's a special space, I think, that may be of research interest concerning the brain and the heart. In the face of scarce oxygen availability, there's some kind of communication that goes on between the brain and the heart, both competing for those scarce oxygen resources. We don't understand that very well. There have been some talk about nerve cells in the organ of the heart itself, as if it has a small brain. And so kind of two brains communicating over scarce reserves in kind of final throes of life, if you will. I think there's a research space there that could be of interest that could be explored. These are papers at this IEEE conference, 2 posters and 2 oral presentations, and we have something coming up soon. I want to just mention heart on a chip or in vitro biodigital twin projects. We have short-term, middle-term, long-term goals affiliated with it. At the Technical University of Munich, we've been looking at different types of biomaterials for developing sensors and robotics technologies. We've discovered or created all these technologies related to in vitro devices, in vivo devices, and so forth already. Some of these technologies support hard on the chip. Some of these technologies will ultimately support implantable electronics that could help with kind of informing the cardiovascular biodigital twin for someone who's not hospitalized, some kind of invasive measurements and so forth, and other clinical applications. I mentioned Kit Parker. He's at Harvard May Lab. We have two people. One of them, Dr. Teshima, is at Technical University of Munich, and Mr. Ishii is at Harvard Lab. They're placed in those two locations, and we're working collectively with a convergence of scientific interest toward developing basically three-dimensional ventricle that's in a dish that will be instrumented with electronics so that we could study electromechanical behavior for a ventricle that's derived from a patient's own stem cells, so patient-specific shaft therapy being developed. Kit Parker is developing that kind of ventricle, and Technical University of Munich is developing some way to stimulate and record from that kind of ventricle in a dish or in a chamber. And then finally, we're pursuing additional funding with ARPAH, which is Advanced Research something. It's similar to DARPA, where the government provides a substantial amount of money for ideas that are highly innovative. And the idea of ARPAH is that by innovative, they mean maybe 50% of people think it may be possible, and 50% of people think you must be nuts. That's the kind of space where ARPAH tends to fund. I appreciate your time, and that's my early presentation. I would appreciate questions and comments.